I am Jeff Burns. I co-direct the Alzheimer's Disease Research Center. I know you're used to seeing Dr. Townley. Today it's my turn, and I am going to talk about preventing dementia and sort of practical advice for your patients, and what you can do to answer that question that you get about how do I keep my brain healthy, and kind of what do we know. So that's what I'll be talking about. My disclosures there at the bottom shouldn't be relevant to lifestyle, but yeah. So the big question that we get all the time, and I suspect you get all the time, is, hey doc, I want to keep my brain healthy. What can I do? What should I be doing? And there's a lot of progress being made in this area of sort of, what can you as a patient, as an individual, do to reduce your long-term risk. We're working on drugs too. So I'll touch on that, but mainly I'm gonna talk about the sort of lifestyle approaches that you can encourage in your patients. And so we've gotten this question for years, and we finally got around about 6 or 7 years ago, actually, to writing a book to answer that question. And we have a really nice book and a nice booklet. You can't really see me, but got a really nice booklet that answers this question, kind of puts it all together for patients. And we give these books out in our clinic. But the program, we call it LEAP, Lifestyle Empowerment for Alzheimer's Prevention. And it's a program we put together to really answer this question. What's the latest evidence, and what's our best advice for what we know today for what a patient should be doing to keep their brain healthy? I'm going to walk through the main tenets of that, but it's the common sense stuff that you'd expect. But with this program, we would love it actually if you found it useful for your patients. We have things like, here's a brain health boot camp that we do. We do in person, we do on Zoom. We have a Mediterranean diet course. We have our book. People can buy that on Amazon. It's $30, but we also have them here. And then actually, we could, if you get this question a lot and you want this booklet, we could provide those to you. So let us know. But hook your patients up to these things. So this is my advertisement, but I'm going to get into the meat of the talk now and kind of walk through the evidence, some of the evidence and some of the advice that we give. So I like starting with this slide, because this shows coronary artery death rates from 1950 to 2010. And that red line is dropping, beginning in the 1970s. And, what's driving that decline is the advances in the science, really driven by understanding the risk factors for coronary artery disease in the 60s. The Framingham Heart Study results started coming out, and the links with lifestyle and cholesterol, and led to strategies to go after those risk factors. Also, drugs, other drugs, some technology. We started bending the curve, and there's been this sustained decline in coronary artery deaths, since 1970. So I love this figure, because I think neurology and sort of the science of dementia is sitting right here in the 1970s. We're behind, but we're beginning to understand the risk factors, and we're beginning to understand what we can do to bring the risk down. So I'll talk a little bit more about that, but it's going to take everything to do this. But we're already doing it. And so, what are we learning? Well, this kind of sums it up the best, I think. And I don't know if you've seen this from the Lancet Commission. It's a couple years old now, but it's a life course model. This line here, gray line over here, represents the life course. And I know you can't see them very well here or at all, but each of these little circles is a risk factor. There's 12 factors that are fairly strongly linked with dementia risk. Things like education in childhood and middle age, hearing loss, traumatic brain injury, high blood pressure, alcohol abuse, obesity, and then in late life, things like depression, social isolation, physical inactivity, diabetes, and air pollution. and smoking are risk factors linked with Alzheimer's. And these things are preventable. These things are modifiable for the most part. And so focusing on these, we think, is something that, we need to do more and more of, because if we can modify these risk factors, we may be able to reduce an individual's risk. So that the message now is be ambitious about prevention. We need to be ambitious at the individual level. We need to empower people, hence our lifestyle empowerment for Alzheimer's prevention program. But we also need to think on the policy level. What can we do at the population health level to push, reduction in these risk factors to drive better brain health? And it's not too early to start doing that. This was written in 2021 or published in 2021, and basically saying it's not too early to start moving these ideas, moving this evidence into practice. And we need to find ways to do that. And it starts with sort of education, but we need programs, and we need ways to turn these strategies into real life action. So this is great. We love this because this is one of the things we've been focused on for 20 years, lifestyle and prevention. Before people were talking about prevention, we were thinking about it and focusing on it. And we sort of planted our flag right in the middle of exercise and diet related stuff to promote brain health in the early 2000s, when we began establishing what became our Alzheimer's Disease Research Center. And so we're now one of 33 nationally designated Alzheimer's centers. It's a big deal to get one of these designations. It takes a huge, 1,000-page grant, and took us 7 years to get designated. And it means we have a whole lot going on. We've sort of broken into this club because we've proven we have the research, we have the clinical care, we have the education programming, and we have it all sort of aligned and working together to support and move forward the science. And part of that science is, as I mentioned, exercise. We're leaders in this exercise, an exercise science in terms of understanding, does it help the brain, and can we use it to fight Alzheimer's? And we've done a series of studies going way back to, say, beginning probably 2005. And we've shown, through these studies that evidence, we still have a ways to go to truly prove this and understand it. But our evidence suggests, consistent with others, that exercise has modest brain benefits, even at low doses. Going from 0 to something is your biggest bang for your buck. So if you got somebody who's sedentary and they want to know how much, say, just get going consistently. Because, we showed that 75 minutes a week, so 15 minutes, 5 days a week, was enough to show some benefits to the brain in terms of cognitive function, covered by the New York Times in 2015. And we've also shown some evidence that exercise may slow Alzheimer's related changes, memory change, and hippocampal atrophy over a 6-month period in patients with Alzheimer's, also covered by the New York Times. I think a year later, 2017. So, and we've done another study where we were testing, does exercise impact the amyloid in the brain? And the answer was no, we didn't see any impact. So we think it may have metabolic effects or neurovascular effects that might mediate these benefits. And so, the evidence is mounting that, and I think we know this. I think most people sort of accept this. We don't quite, because the science evidence is still needs some boosting. You could ask why, but we think there are policy reasons and things like that. But so we're working hard to take this further and understand more about exercise. But we're also studying diet. We're actually a leader in diet studies. Diet, we're developing drugs that go after metabolism. Russ Swerdlow leads a lot of work on mitochondria, and he's a world leader in this space. And so this is our focus as a center, what we've been focused on and thinking about, and really trying as a new target for Alzheimer's disease to try to help prevent and treat Alzheimer's. So, but we think that prevention works. When we talk about prevention, it's not, erase the disease from the face of the earth. That's what we want to do, but lifestyle is not going to do that. And so the impact of prevention or delaying the onset is this here, that if we can postpone the onset, the average age of onset by 5 years across the population, we'll cut the incidence of Alzheimer's in half. So that's a really big deal. if we can just delay it a few years, that can have a big impact in terms of population health. And so, even if we have drugs in the future, and we do have new drugs for Alzheimer's, we still think lifestyle is going to play a role, just like in cardiac disease. There are drugs, but lifestyle is still important. We believe the same will be true of brain health, and that it's true now. And so these are the sort of 6 brain healthy lifestyle strategies that we focus on in our book, in our classes that we give. And then when we're sort of preaching, in those few seconds you have to talk about it with patients, stay active, eat well. I'll talk a little bit about, just more specific than that. Eat well, control any stress, stay engaged with people, stay engaged cognitively, and sleep well. And so that's really it. It's common sense stuff, but that's the kind of recommendation. Exercise, improve your diet, sleep well, keep your brain active, move more, and keep your brain active. So, what is the prescription for exercise that we sort of preach, and that the associations and others have said, this is the right amount. It's 150 minutes of moderate intensity aerobic exercise a week. So 30 minutes, 5 days a week. Moderate intensity means, pushing yourself a bit to get a little bit out of breath, get your heart rate up a little bit and break a sweat. That's walking for most older adults. So that's it. I don't think it's all that important to focus on a threshold, achieving 150 minutes a week. Our study showed that 75 minutes of moderate intensity aerobic exercise was enough. I think the right thing to coach your patients on is just get going, start a habit, even 10 minutes a day. Hopefully they do more. But even 10 minutes a day is good for you, because as I mentioned earlier, going from 0 to something is where you get your biggest gain, your biggest bang for your buck. And so get them started. I once read some book where someone was quoted as saying, I don't tell people to floss their teeth. I tell them just focus on flossing 1 tooth a day. And the point being, no one's going to do that. If you focus on just doing 1 a day, that's a simple goal. They'll do it, but they're going to do all their teeth. So focus on doing something every day, even if it's 10 minutes, just out and back, 5 minutes out, 5 minutes back, and they'll hopefully build a habit and get it into their life and do more than that. So what do we define as healthy eating? And that's one where everybody has an opinion, and probably the most scientific evidence is around Mediterranean diet. And plus, this shifts too. What is healthy shifts. I know in the 70s and 80s, it was low fat, high carb, and we're not there anymore. Now we think a Mediterranean diet is the right pattern. It's not a diet. It's not a restrictive diet. It's a pattern where we're focused on more vegetables and fruits, whole grains, healthy fats, lean proteins. Healthy fats are, avocado, olive oils, not the vegetable oils that we like, but a lot of olive oil, a lot of healthy fats, not a lot of carbs. And when we do have carbs, it's more whole grains. So limited processed foods and sugar. That's the Mediterranean diet pattern. Pretty good evidence, at least in epidemiologic studies, actually very good, that it's associated with a lower risk of dying, so mortality, but also Alzheimer's. And so we're studying that now in terms of, if, the big question is, all right, great, we got this evidence from these observational epidemiology studies that shows, the people who eat a Mediterranean diet pattern are at lower risk of death, lower risk of Alzheimer's. But the big question is that the cause, or there are other things that are driving that association between a Mediterranean diet pattern and Alzheimer's, like socioeconomic status or education? And so now we're testing through randomized trials, if you start a Mediterranean diet or you shift your pattern newly to a Mediterranean diet pattern, does that impact the brain in a positive way? Does it cause an effect? Is it the cause of the effect of a healthier brain? And that's where we get tied up. We're trying to take epidemiology data and make it cause and effect, and that's hard to do. And so that's why we need randomized trials to understand this better. So we're in the process of doing that, or at least trying to do that. So more to come. But now sleep, we just tell people high quality, 7 to 9 hours is good. If look for sleep apnea. Sleep apnea is bad. Low oxygen levels, poor sleep for years, and that can impact mood. That can impact, thinking. That can impact cognition. And so, as physicians and clinicians look for that, screen for it. Insomnia. People have insomnia. We like melatonin, and it's sort of so gentle and can help some patients. If we have to, trazodone can be helpful, and SSRIs can help if people are anxious or depressed. We look a lot for REM sleep behavior disorder because we see it so often in dementia with Lewy bodies. And then, refer to a sleep specialist if you see these things and are having difficulty treating them. What about cognitive and social activity? More is better, right? People always ask, should I be doing crosswords? Well, there's nothing magical about a crossword. It's keep your brain active. We think that's helpful. Now, the hard part here is, you can train somebody to do something and they're going to do better at it. And so we know if we do give people brain games, they're going to get better at those brain games. But the real question is, does it translate? Does it carry over into daily life? And that we don't know yet. And then does it translate into a lower risk of dementia? It's not a slam dunk case, but people whose minds are more active tend to be at a lower risk long-term of dementia. And so with that, we tell people stay active, keep your cognitive diet active, stay involved in novel things and socialize and get involved with your community as much as you can and do things you love. If you're asking about crosswords and they have never done crosswords before, not good advice to say start doing crosswords because they'll do it for a day or two and they'll quit. But it's things that they really like, and it can be anything from socializing to Sudoku and brain games and other things. So, all right. So basically, and now I'm kind of wrapping it up. So that's sort of the advice we give, and our goal, sort of as scientists in the Alzheimer's Research Center, is how do we maximize this impact of these findings and what we're learning about risk factors and risk reduction. And again, I think prevention is achievable, and that meaning delaying the onset of Alzheimer's is achievable. And we need more understanding. We need more data to understand it on an individual level, and we need to scale it up to a population level. And what I mean by that is, if we know exercise helps, we're not doing a very good job of getting older adults to exercise. I mean, we can do better as clinicians. And so there's other things too: lowering blood pressure, diabetes therapy, vascular risk reduction. We need to develop better programs and more effective ways to change people's lifestyle. So the idea of lifestyle medicine is a relatively new sort of field. Is how do we get these learnings about lifestyle into people's lives? And it's going to take new programs, new care delivery methods, technology, et cetera. So we're working on that from a couple angles to apply these learnings to a larger, broader population. And we can do that by leveraging the electronic medical record and through pragmatic trials. And I'll give you an example of two of those right now. And one is, if exercise works, we aren't using it well enough. We don't have tools as clinicians to prescribe it that we know are effective. And so we developed the LEAP-RX program, which was a pragmatic trial where clinicians could prescribe it by clicking a button, and we would, with your loved best practice alerts, we would hook them up with a program that lasted a year. They had a trainer, they had a fitness center, and through this, we actually showed we can boost cardiorespiratory fitness. We can boost heart and lung function for those individuals who were randomized to this program. And so, this is one attempt of ours to basically package and prescribe exercise from beginning in, at the point of care in the clinic, and then, into the community using community fitness centers. Here's another. This is really complicated here, but the idea is, as patients come in to our health system and they get their blood pressure measured, then we identify those who have uncontrolled hypertension, and we automatically enroll them into our blood pressure program, which is a pharmacist-led program. And the pharmacists become part of the primary care team in helping control the blood pressure. We do it all virtually, some of you, if you're in the KU Health System, you probably have some patients who are part of this virtual collaborative care clinic, the VCCC. And hopefully it's making your job easier and your patient outcomes are getting better. So that's the idea. Is, we automatically identify these patients and we automatically, expand the care team to include pharmacists who call patients, watch their home blood pressure monitoring, and call patients and, add prescriptions to better control their blood pressure. So we're testing this at 2 sites here and at the University of Utah. We've enrolled close to 700 of the 1,000 patients. Pretty cool project and big impact. And now this is the research stuff that we have to do. It's a little complicated, but we want to show that we have good outcomes with blood pressure and good outcomes with cognition, ideally. But the idea here is we're harnessing the health system and the electronic medical record, and we're trying to scale up what we know about aggressive blood pressure control, which is it can reduce the risk of MCI, mild cognitive impairment, and dementia. So, okay, so wrapping it up, two more slides. One is this: clinical practice is pretty rapidly moving towards this world, where we will pretty soon be detecting Alzheimer's changes before the onset of symptoms with blood tests. And hopefully we're going to have proven interventions to delay the onset, halt it, or reverse it. That's coming. We have blood-based biomarkers coming. You're gonna hear about these if you haven't already. You're going to start hearing about it more and more over the next year. But this is the world we are pushing hard to get to, and it's coming someday. And I'll just end on this: that here is data from 2017. Each line represents dementia incidence over time. So think about it this way: 30 years ago, the risk of somebody who in these various age groups is on the left, versus today, their risk level is on the right, and the lines are sloping downward. That means today, a given individual's risk of dementia is lower than an individual's 30 years ago. So we are seeing signs that dementia incidence and dementia risk across the population is decreasing today compared to 30 years ago. Pretty convincing evidence. Now, the numbers of people with Alzheimer's is going way up. That's because we have such a huge number of individuals at risk given the aging population. But I think we are already beginning to bend the curve. This is evidence that we're already beginning to bend the curve in terms of dementia risk. And we're just getting started. So that's it. I will say, our goal with these talks, with everything we're doing, we're trying to invent and create ways to support you and support your patients. Pocket Talks is one of those, but we have other resources, our education opportunities like LEAP for patients and families. Tell your patients to, and even you, sign up for this My Alliance for Brain Health. It's 1 email a week. And, it's a great way to stay connected and link up with us and get your patients linked up for free programs like LEAP and we do weekly webinars and for patients and families. And if you have patients, we need them in research. If they're asking questions about research, you can refer them. If you're in the health system with a referral, an order for the ambulatory referral to Alzheimer's research, and we can figure out if they are eligible for research. But if you're in the community, you can send them to our referral survey or reach out to me or send them to our website. And so we're always looking for ways to do that. So, okay. So I'll stop there, and we have a couple minutes. If there's any questions, we're 5 minutes early. I'm happy to take questions or get you back to patient care. And there is a message: don't forget to claim your CME credit for today. And the code is in the chat. Questions, comments? It doesn't look like it. So I will say we're super excited about these blood-based. I'll wrap it up with this last comment: that these blood-based biomarkers are coming, and we want to get them. We're going to be working on projects to to get them sort of built into practice in our practice here, but also in primary care practice, to figure out who are the right patients to refer on for specialty care, or refer on for consideration for the new drugs. You'll hopefully hear more about, if you're in the KU system, you'll hear more about that. And then, yeah, so I'm sorry, I got a message from Ryan Townley that we do have Spark on dementia with Lewy bodies this week, tomorrow morning. If you've seen that, it's great for families. It's all about dementia with Lewy bodies. So, all right. Well, we'll wrap it up. So thank you guys for attending, and thanks for being a part of our effort.